We are thrilled to have Dr. Liz Shlom as our guest who will present. Dr. Liz Shlom is a clinical pharmacist who has been providing the NYSCHP with an annual presentation on new FDA drug approvals for many years. Liz is a past president of the NYSCHP and also served as chair of the House of Delegates and director of education and workforce development. Liz was previously the vice president of the clinical pharmacy program at Premier Acuity and Greater New York Hospital Association services for over 25 years. Please join me in welcoming Dr. Shlom. Before we get started, I'd like to share some quick points. For those who have technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in resolution. For those who have questions that you would like to direct to the speaker, please use the question box or chat option. The CE code for this program will be provided at the end of the program. Thank you.
All righty. Well, thank you for the introduction, and thanks everybody for joining tonight. We're going to be talking about drug approvals update, focus on 2022. So here are the objectives of the presentation. By the end of the activity, you should be able to discuss new molecular entities approved by the FDA in 2022, match a list of new medications with their indications, describe some safety concerns of the new medications, and discuss the advancement of biologics and gene therapies. I do want to mention I don't have any disclosures to report, and I will be using both generic and brand names of medications, and I may be discussing some off-label indications as well. So this is a chart that I do every year to show you the progression of new drug approvals every year, like for the last 10 to 11 years. So if you look at 2022 on the right side of the chart, the yellow line represents the total number of drug approvals of 2022. There were 37 in 2022. There were, of these, 22 were non-biologics, so small molecule drugs, and then 15 were monoclonal antibodies. So you can compare with the previous years, and you see that this was actually a lower number of total drug approvals ever since 2016, which was actually much lower, but the last 5 years have been much higher in number. So we have a little bit of a downturn in 2022. I do also want to mention that these are the FDA drug approvals that came through the FDA Center for Drug Evaluation and Research, which is abbreviated as CDER, C-D-E-R. We call it CDER. There are also drugs that are approved through CBER, which is the Center for Biologic Evaluation and Research. And those are mostly biological medications that are more complex than those that go through CDER. We will actually talk about some of those at the very end of the presentation, but the majority of these drugs, the 37, these are all through CDER in the FDA. So there are a few approval designations that I'll be speaking about. Orphan drugs and first-in-class are a couple of those. So orphan drugs, for those of you who aren't aware, these are drugs or biological products that are approved for a rare disease or condition. So these are for populations of 200,000 or fewer people in the US. And then first-in-class drugs are those with a new mechanism of action. And the benefit that the companies receive for first-in-class drugs is that surrogate endpoints can be used in the clinical trials if the drug fills an unmet medical need. So I do want to show you that the graph that I have down there on the bottom compares 2022, the percentage of orphan drugs that were approved of the total drug approvals and the first-in-class compared to the other 4 years in the most recent past. So you can see that orphan drugs have been about a little over half of the new drug approvals for the last 5 years, except for 1 year. And as far as first-in-class, we now have in the last 2 years that over half of the new drugs are first-in-class agents. We'll also be talking about priority review and breakthrough therapies. With priority review, these are agents that are given an expedited FDA review with action on the new drug application within 6 months. The standard review is 10 months, so that's an extra few months that the manufacturer can get the drug onto the market. This is only for drugs that are providing significant improvements in safety or effectiveness. And the FDA does decide this designation for every application that comes through. Breakthrough therapy is for is a designation when a drug provides substantial improvement over current therapies. This can be requested by the manufacturer, or the FDA might even suggest it after they review some of the preliminary information. One of the big benefits to breakthrough therapy designation is that if early in the process of going through the way to get it approved by the FDA, the manufacturer can actually get a lot of insight from the FDA on things that they need to do to get the NDA through the process. So there's much more intensive help from the FDA to get that drug to market. So if you look at the percentage in 2022 compared to the past, actually there were a lower percentage with priority review in 2022 than what we've been seeing lately. But with breakthrough therapies, we have a higher percentage than some of the past years. So it's just to give you some perspective. Now we're going to start talking about the new drugs themselves. And I have broken them down into different disease categories. So we're going to start off with some new anti-infective medications. So we have two agents here. The first one is lenacapavir, Sunlenca. This is a first-in-class agent that got priority review and is a breakthrough therapy designation. So this drug was approved in August of 2022. It's a capsid inhibitor that interferes with HIV-1 viral replication, both in early and late stages of the viral life cycle. It's indicated for multi-drug resistant HIV infection in combination with other antiretrovirals. So the dosing of this medication is by sub-Q injection. It's every 6 months, so that's a long-acting preparation. But if you look at the initiation therapy for this, you have two options. One of those is sub-Q first, and then oral formulation of the drug, and then a second dose of the oral formulation, and then you go into the every 6-month sub-Q injection. And then the second option has more of an oral therapy to begin with before you go into the every 6 months in maintenance therapy. So why is there an oral formulation, but it's not indicated for maintenance therapy? That's because the sub-Q injection is basically a reservoir type drug where it has a slow release from the injection site. And because of that, the injectable formulation, excuse my cat, actually has a half-life of 8 to 12 weeks versus the oral medication has a half-life of 10 to 12 days. So the FDA agreed with the manufacturer that only the sub-Q injection would be approved for the maintenance dosing. So as far as safety considerations and common adverse effects, in order to make sure that I go through all of the information that I need to get through tonight, I'm going to skim over a lot of this information so that we can, like I said, get through the other drugs as well. So the only thing I wanted to point out with the safety considerations is the immune reconstitution syndrome, which is an inflammatory response to indolent or residual opportunistic infections. So this is something to be aware of when patients are started or initiated on Sunlenca, that if they have an indolent infection such as CMV or TB, MAI, then this might bring that infection to the surface. And then you can see that adverse reactions generally are mild or moderate in severity. So with each one of these drugs, I will provide you with information on the clinical trials that brought it to market, and then give you an update on where its place in therapy is, or if there's other trials that they're looking for other indications, or if it's an orphan drug, some information about the orphan disease. So most of the clinical trials, I'll tell you also, generally they're comparing the product against placebo. In some cases of all these drugs, there are some situations where there was an active drug that was compared to this experimental drug as well, but the large majority are compared to placebo. So in this case, the medication was for multi-drug resistant HIV. So patients were receiving background therapies or therapies that maybe the patient wasn't being treated successfully, but this drug is being added on because it's for multi-drug resistant. But overall, they did see a benefit with this medication when it was either added on, to other therapies. As far as ongoing trials, they are also looking at lenacapavir as a single agent for pre-exposure prophylaxis in people at risk for HIV, and also for management of treatment-naive HIV patients with a CD4 count, cell count of 200 or higher. And they're also looking at the oral formulation in combination with bictegravir for virologically suppressed treatment-experienced HIV patients on complex regimens. So those are just some other things that might be coming up in the future for this drug. Moving along to our second drug, we have oteseconazole or Vivjoa. This is an azole antifungal agent. It did get priority review. It's not the first in class. As you know, there's other azole antifungals out there. However, it is the first drug that's approved for this indication of recurrent vulvovaginal candidiasis, specifically in patients who are not of reproductive potential. It does have embryo-fetal toxicity, as you can see under safety conditions. So that's why it cannot be used in patients who are either of reproductive potential, pregnant, or lactating. So the dosing options are listed there. And the one thing I wanted to mention is that there are two dosing options. One of those is completely with oteseconazole with a 600 milligram dose on the first day, and then 450 milligrams on the second day. Then on day 14, 150 milligram once weekly for 11 weeks to complete actually a total of 11 weeks therapy. The second dosing option actually has fluconazole for the first 3 doses every 72 hours, and then it starts in with oteseconazole. So there are clinical trials where they looked at fluconazole in addition or in comparison to oteseconazole and saw benefit. Okay, so we'll move along to the second slide here. So we have 2 sets of trials for oteseconazole. We have the violet trials and the ultraviolet trial. Just love the names that they pick for all these different trials. The violet trials were internationally done. These were randomized, multi-center, double-blind, placebo control, multinational trials in women who had recurrent vulvovaginal candidiasis. And they did see that fluconazole was being used first, and then the maintenance dose of oteseconazole was being used after that. So when they looked at the results, they basically compared oteseconazole versus placebo, and they did see that there was an advantage, of course. In the ultraviolet trial, this is being done focused in the US, a randomized double-blind trial in women with recurrent vulvovaginal candidiasis. And here they also saw that patients had a significant improvement with oteseconazole compared to fluconazole. So this was an either or. They either got oteseconazole or they got fluconazole for those first 3 doses, and then they got placebo for the rest of the time, so that it was a randomized double-blind trial. So in this case, oteseconazole was showing improvement versus fluconazole. Okay, we're going to move along to our next category, which is blood disorders. We have 3 products here: sutimlimab and JMO, mitapivat, which is Pyrukynd, and pacritinib, which is Vonjo. First one is sutimlimab and JMO. This is a complement C1 inhibitor that's indicated for the treatment of hemolysis with cold agglutinin disease. Cold agglutinin disease is an orphan disease. This is a first-in-class agent, got priority review and breakthrough therapy status. The medication is administered as an IV infusion over 60 minutes. It is weight-based dosing. It's done weekly for 2 weeks and then every other week after that. So there, in this case, the patients can develop infections. And actually, if you look at the most common adverse reactions, infections were the highest occurring adverse reactions, and that is because complement inhibitor is a helper for your autoimmune system. So with this inhibitor, it's allowing infections to take place. So also there's potential for developing autoimmune diseases such as lupus with this drug. So what is cold agglutinin disease? This is a complex disease. It's an autoimmune disease with hemolytic anemia. There's abnormal bone marrow cells producing antibodies called cold agglutinins. These cold agglutinins attach to red blood cells and activate the complement pathway of the immune system to target the red blood cells, and that leads to hemolysis. So C1 or complement 1 is the primary complement protein involved in cold agglutinin disease. The symptoms are similar to what you would expect with somebody who has anemia: fatigue, weakness, shortness of breath, dizziness, etc. And also it's noted that cold temperatures or a compromised immune system can trigger the symptoms. That's why it's called cold agglutinin disease. It's most commonly seen in older adults. The median age of onset is 65 years. So the clinical trials are listed there. Cardinal trial was an open label single arm trial in only 24 patients. And the Cadenza trial was a 6-month placebo-controlled phase 3 trial in 22 patients. And in both, they did find that this product was better than placebo. The next product is mitapivat, or Pyrukynd. This is also for an orphan disease, which is hemolytic anemia in adults with pyruvate kinase deficiency. This drug also had priority review. It's a pyruvate kinase activator. It's first in class, as I mentioned. So this is the first disease-modifying agent for this illness. That's why it received priority review. So the dosing is oral. It's administered as twice daily for weeks 1 through 4. It's 5 milligrams. Then the dose is increased weeks 5 through 8. And then weeks 9 and beyond, it's continued at an even higher dose. So basically, you're increasing the dose over time. So the dose increase is based on the hemoglobin levels and transfusion requirements. If the patient is not having any response by 24 weeks, then the medication can be discontinued because it's not going to help the patient. Some of the considerations with this drug is that abrupt discontinuation or interruption can lead to acute hemolysis. So that's something you definitely want to avoid. It should be avoided with moderate or severe hepatic impairment, and there are drug interactions to be considered. So looking at the orphan disease, pyruvate kinase deficiency is a rare autosomal recessive disease that results in chronic hemolytic anemia. And here are the most frequent symptoms: of course, anemia, splenomegaly, jaundice, gallstones. These are all seen with this disease. The treatments typically are supportive with folic acid. If B12 is deficient, then that is also administered, and transfusions as needed. Typically, patients are offered splenectomy to reduce the transfusion requirements. Hematopoietic stem cell transplant may be of benefit, and gene therapy is under investigation. But this is the first medication that is indicated that can be taken aside from those. So there are 2 clinical trials, and again, they basically found the mitapivat was more successful than placebo. And our next agent is pacritinib, or Vonjo, also an orphan disease, orphan drug, and priority review. This is a kinase inhibitor that targets JAK2 and FLT3 kinases. So it's got that tinib end to the name, the generic name, that goes to show that it's a kinase inhibitor. And usually kinase inhibitors are oral, so this one is as well, 200 milligrams orally twice a day, with or without food. So this drug is for the orphan disease myelofibrosis, and specifically for the disease that's intermediate or high risk. It could either be primary or secondary as a result of post-polycythemia vera or post-essential thrombocythemia, and with a platelet count below 50. Some safety considerations or drug interactions also can lead to severe bleeding and hemorrhage. So if a patient has planned surgery, you'd want to hold the drug beforehand. And also if the patient has an active bleeding episode. It also should be avoided in patients with prolonged QT intervals and with moderate or severe hepatic impairment, or GFR less than 30. And then some of the adverse effects are listed there. So this orphan disease, myelofibrosis, is a rare and complex disease in which there's a disruption of the blood cell production and extensive scarring in the bone marrow. This leads to severe anemia and a reduced platelet count. It can increase the risk of bleeding and cause the spleen to enlarge. And as mentioned before, it can either be primary or secondary, occurring on its own or developing due to another bone marrow disorder. So the clinical trial was the PERSIST-2, and here they did compare pacritinib to best available therapy, which included ruxolitinib, which is also a JAK inhibitor, JAK inhibitor. And they did see that pacritinib was more effective than placebo, and it was also more effective than best available therapy in both endpoints. Okay, we have one new cardiology medication, and you might be familiar with this one. I know there are some centers being set up around the US for patients that are going to be put on this medication. So mavacamten Camzyos is a first-in-class cardiac myosin inhibitor for an orphan disease, and it's a breakthrough therapy designation. The indication for mavacamten is to improve functional capacity and reduce symptoms of symptomatic New York Heart Association class 2 through 3 obstructive hypertrophic cardiomyopathy. So essentially, this is for HFpEF, heart failure with preserved ejection fraction. And as a matter of fact, it can only be used in patients who have a left ventricular ejection fraction of 55% or more. It should not be used in patients with a lower ejection fraction. There's actually a REMS program that focuses on that to make sure that only the most appropriate patients are receiving it. And also because patients do have to be monitored during treatment at a regular interval. And so the REMS program is to make sure that the patients are being monitored and that no drug contraindications are being administered at the same time. So that's some of the issues that you want to think about with mavacamten. What is obstructive hypertrophic cardiomyopathy? That's a stiffened heart muscle that obstructs the blood flow being pumped out to the rest of the body. The symptoms are listed there. And the current treatments are, for the most part, based on the symptoms. So there's beta blockers, non-dihydropyridine calcium channel blockers, and disopyramide. But the cardiac myosin inhibitors are really focusing on what's actually happening in the heart with this interaction with cardiac and myosin, or actin and myosin, to increase the pumping of the heart. So the inhibitor slows down the rate of the heart and allows for better pumping of the blood to go out. So mavacamten is the drug that was approved. Aficamten is another drug that's in development to target that underlying pathophysiology of this disease. And then you can see the information there. Compared to placebo in the clinical trial, it was found to be more effective. Okay, so we have 6 new medications that have dermatology indications. First of those is abrocitinib, or Cibinqo. This is a priority and breakthrough drug. It's a Janus kinase inhibitor, the tinib again at the end there, so it's a kinase inhibitor. It's for atopic dermatitis, also known as eczema, in patients 12 years and older with disease that's refractory and moderate to severe. The dosing is oral, once daily, and it starts at 100 milligrams, can increase to 200 milligrams. Should be adjusted for renal impairment, or if the patient is a CYP2C19 poor metabolizer, because poor metabolizers have a longer half-life than those that are not poor metabolizers. Also you need to avoid concomitant use of other JAK inhibitors, biologic immunomodulators, or immunosuppressants. There is a boxed warning: the increased risk of infection, malignancies, thrombosis, and major adverse cardiac events. Oops, pressing the wrong buttons here. There we go. Okay, so the phase 2 clinical trials, there's actually a number of them. They're called the JADE trials. There's 2 that looked at monotherapy of abrocitinib for this indication, and they both were found to be more effective, with the different doses of abrocitinib than placebo. And then there were other phase 3 trials that use combination therapy or looked at in different patient populations, such as the JADE-TEEN clinical trial, which looked at patients that were 12 to less than 18 years of age. So in all of these, abrocitinib at either 100 or 200 milligrams showed significant response versus placebo. And then there's just some information about atopic dermatitis and what the current treatments are, where this would fit into the moderate to severe disease category. Our next product is daxibotulinum toxin A, or Daxxify. I won't talk too much about this. It's basically another botulinum toxin product that is available for temporary improvement in moderate to severe frown lines in adult patients. It is administered with the 5 injections, but the one advantage of this drug, it says here, administer no more frequently than every 3 months, but they're actually finding that it is effective up to 6 months. So that is the benefit that this drug does bring to the current market, because most of the other drugs last as long as maybe 3 months, but this may only need to be redosed every 6 months. And there's the list of other botulinum toxins that are available for this indication, and some of the considerations, which is the longer duration of effectiveness. There's no human or animal additives in this product, and it can be stored at room temperature. Our next product is Anacalase, or Nexobrid. This is an orphan drug. I thought this was actually a pretty interesting drug. I don't know if you're seeing it in the hospitals if you have a burn center. It's for the eschar removal in adults with thermal burns, and it's a proteolytic enzyme that's extracted from pineapple plant stems. So it's a botanical drug product that's being used in a topical application to help remove that eschar or eschar. I'm not sure exactly how to say that. But you can use it for up to 20% body surface area of the patient, but you would have to apply first up to 15% of body surface area. And then if you needed to do, a larger area, you could go to that, further 20% body surface area at least 24 hours after the first application. So just by itself, it helps to remove the eschar. You do need to provide pain management as you would for dressing changes. As far as safety considerations, it's not for chemical burns, shouldn't be used on any sensitive areas of the body. Also have to be careful in patients with cardiovascular disease. So the drug actually provides significant benefit to these burn patients, because I think at the current time, what most patients have to go through is surgical debridement. So this allows for less surgical debridement to take place. There's a lower incidence of surgical eschar removal compared to standard of care. So in the trials, they looked at standard of care versus this product and found that it was at least non-inferior in time to 95% wound closure, but also shorter time to eschar removal and lower incidence of surgical. I did notice that the US is the 44th country to approve the use of this drug in thermal burns, which I thought was pretty interesting. I'm not sure why it didn't make it to market earlier, but as far as I'm aware, it may not be available yet. From what I saw, they said availability is expected in the second quarter of 2023. The next product is spesolimab, okay, little tongue twister, Spevigo, which is a first-in-class orphan drug with priority review and breakthrough therapy status. This is a human interleukin-36 receptor antagonist for generalized pustular psoriasis flares in adults. So it's only for the flares. It's dosed as a single IV infusion over 90 minutes. And if the symptoms persist, a second dose can be administered a week after the first dose. So there are hypersensitivity reactions that can occur, including DRESS syndrome, which is drug reaction with eosinophilia and systemic symptoms. And they actually noted that in the trial, the clinical trial, with 35 patients, there were 2 cases of DRESS syndrome. So it may occur more often than that in regular usage. The adverse effects are listed there. So what are GPP flares? It is a rare and potentially life-threatening autoinflammatory skin disease. The significance is that there is mortality associated with these, resulting from septic shock and cardiorespiratory failure. So it is important that it is treated, and also to manage the triggers, upper respiratory tract infection, stress, certain medications, medication withdrawal, pregnancy can all induce these flares. So I'm sure this is something that these patients are definitely aware of, and when I have treated. So they have noticed that also that the IL-36 cytokines are overexpressed in the GPP skin lesions, which is why they brought this drug to market. And it was found to be in the 53 patients that were in the clinical trials. They did find that it provided significant improvement over standard of care or placebo. Our next product is deucravacitinib, or Sotyktu. You may be familiar with this. I know there's been a lot of commercials for it. It is a first-in-class medication for moderate to severe plaque psoriasis in adults. It's a tyrosine kinase 2 or TYK2 inhibitor. It's orally administered 6 milligrams once daily. It does have an increased risk of infection. You have to evaluate for TB prior to treatment. Should not be used in combination with other potent immunosuppressants, and is not recommended in patients with severe hepatic failure. So plaque psoriasis treatment basically has 3 lines of therapies. First line is the topical agents, corticosteroids, vitamin D analogs, etc. Second line would be phototherapy or oral agents, which is where this would fall because it is an oral agent. And then third line is the biologics, including etanercept, adalimumab, infliximab, etc. So in the phase 3 clinical trials for deucravacitinib, they did include apremilast, which you see is actually under second and third line agents for this disease. And they did find that it was it provided a better outcome than apremilast. So that is something to be of note. And this would be a second line agent for plaque psoriasis. Our next product is tapinarof or Vitama. This is a first-in-class. It's an aryl hydrocarbon receptor agonist, and it's also for plaque psoriasis, but it's a topical treatment. So based on the previous slide, it would be first-line therapy. Here, you apply a thin layer of cream to the affected area once daily. And the phase 3 clinical trials did find that it was better than placebo. The vehicle cream was used as a placebo. Okay, we're going to move along to a couple new diagnostic agents. The first of those is gadopiclinol, or Elucerum. This is a priority agent brought to market. It's a macrocyclic gadolinium-based contrast agent, so a GBCA. It's for use with MRI to detect lesions with abnormal vascularity. So the one thing that's notable about this product is that it has a lesser, let me see, I have to get the specific wording here. Let me just find it real quickly. And I can't find it. Okay, it has greater relaxivity than the other gadolinium-based contrast agents. Basically, this can be dosed at a lower dose, half the dose, compared to other gadolinium-based contrast agents. And that's exactly what they did in the phase 3 clinical trials. They compared gadopiclinol with gadobutrol at half the dose of gadobutrol, and they got equivalent, basically non-inferior results. And the reason that this is important is because gadolinium-based contrast agents can accumulate in the body, and they can, over time, if this accumulation occurs, and if the patient has impaired renal function, and actually with higher doses of these medications, there's a risk of nephrogenic systemic fibrosis. So this is a very severe, fatal, and debilitating fibrosis that affects skin, muscle, and internal organs. So by reducing the dose, that may help to reduce the incidence of this adverse reaction. The next product is Xenoview, or Xenon hyperpolarized. This is for use with MRI for evaluation of lung ventilation in patients 12 years and older. So it's given by oral inhalation from an oral inhalation dose bag, and it does help to improve lung ventilation when you're doing an MRI. It doesn't help with lung perfusion, which would be to see how the blood flow is through the lungs. It's only for ventilation of the lungs. Now we're going to cover 2 new medications for endocrine disorders, and my guess is you've heard of both of these drugs. The first is tirzepatide, or Mounjaro. It's a first-in-class agent for type 2 diabetes as an adjunct to diet and exercise. It's a dual agonist of glucose-dependent insulinotropic polypeptide GIP receptor and glucagon-like peptide 1 or GLP-1 receptors. So with that dual agonism that are synergistic in effect, you have a decrease in food intake, a slowing of gastric emptying, increased insulin sensitivity, enhanced first and second phase insulin secretion, and reduced glycogen levels. So it's administered sub-Q once weekly, and you can increase the dose, like you start the dose out low, increase the dose after 4 weeks, and then you can further adjust it. The maximum dose in the package insert is 15 milligrams sub-Q once weekly. I think in the studies, they actually went up to 20 milligrams. One problem with the highest doses, 20 milligrams, and probably why they didn't include that in the package insert, is because there's much higher risk of GI adverse effects with the highest dose. And there were a lot of patients discontinuing the trial because of those GI adverse effects. So there is a box warning here of the risk of thyroid C-cell tumors. So it's contraindicated in patients with a history or family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome. There's also safety consideration with hypoglycemia, and also the delay in gastric emptying can impact the absorption of some other oral medications. There are lots of trials of tirzepatide, the SURPASS trials, and there's also a group of trials called the SURMOUNT trials. It is being studied for obesity, doesn't have the indication yet. However, probably will be coming, but like I mentioned, with higher doses, they did see a lot of GI adverse effects, so I think that might be holding it up. There is a reference there, a quick guide to the SURPASS and SURMOUNT trials in diabetesmedicinemematters.com, which goes through all the different trials, and it's a great review, so I highly recommend it. That's where I got some of this information that I have there, as well as the studies. So, basically, tirzepatide is being shown to be very effective, both at, type 1 diabetes and weight reduction. And then the other new medication in the endocrine category is teplizumab, or Tzield. And this is a first-in-class priority breakthrough drug, CD3-directed antibody that's indicated to delay the onset of stage 3 type 1 diabetes in patients aged 8 years and older with stage 2 type 1 diabetes. This is a daily infusion over at least 30 minutes for 14 days of therapy. And you can see from the schedule there that each day the dose is increased until you get to day 5, then it's continued at that same dose from 5 through 14. Patients do need to be pre-medicated with nonsteroidals or acetaminophen, an antihistamine, and or an antiemetic. It's not recommended for patients with low lymphocytes or low hemoglobin, low platelets, etc. You do have to monitor for cytokine release syndrome and lymphopenia and hypersensitivity reactions. And as you can see under the most common adverse reactions, lymphopenia is very high, occurs at 73% with this medication. So what are the stages of type 1 diabetes? Where does this drug fit really? So you see stage 1 is where, the patient has an underlying problem, but they're normal glycemia, pre-symptomatic. Stage 2 is where they're still pre-symptomatic, but there is dysglycemia. And then stage 3 is where the patient's symptomatic with dysglycemia. So, and the at-risk TN10 trial, this was conducted by a global network of type 1 diabetes researchers. They looked at 76 relatives of patients with type 1 diabetes and at high risk. 72% of the patients in this trial were 18 years of age and younger. So the results of this trial basically were that they found that Tzield or teplizumab did delay the onset of stage 3 type 1 diabetes by 2 years. So that was the outcome. Okay, we have one new medication for gastrointestinal disease, and that is Voquezna, which is vonaprazan, amoxicillin, clarithromycin. It's a first-in-class and priority drug. This is a medication, actually the vonaprazan, of course, is the new portion of the drug, the first-in-class. It's a potassium competitive acid blocker. So it's, being used instead of a PPI, it's a PCAB. So it's used for treatment of H. pylori infection in adults. So it comes either as a triple pack in combination with amoxicillin clarithromycin, or as a dual pack in combination with just the amoxicillin. And both of them are administered for 14 days. So hypersensitivity, severe cutaneous adverse reactions can occur, and clarithromycin component does lead to some adverse reactions. And you can see that the excuse me, the common adverse reactions are listed there for the triple or dual pack. So looking at the phase 3 clinical trials, basically they did look at patients who had clarithromycin or amoxicillin resistant strains, or patients that had just without clarithromycin or amoxicillin resistant strains, and their dual therapy and triple therapy were non-inferior to lansoprazole triple therapy in a 4-week post-treatment eradication rates. They looked at patients with clarithromycin resistant strains, and here the dual therapy and triple therapy were superior to lansoprazole triple therapy. And then when they looked at all patients, basically the dual therapy and triple therapy were superior to lansoprazole triple therapy. So in the treatment options that are over there, there's many options that are out there for H. pylori treatment. The very first one there, the clarithromycin triple therapy with PPI, the trial investigators commented in their study that they felt that this would be where this drug should be placed instead of using the PPI triple therapy, that the PCAB triple therapy might be a better option. Okay, we have 2 new medications for genetic diseases. First of those is vutrisiran, or Amvuttra. This is for an orphan disease. It's a transthyretin-directed small RNA interference agent, and its indication is treatment of polyneuropathy of hereditary transthyretin-mediated amyloidosis. So this is a rare and rapidly progressive, debilitating, and fatal disease that's caused by a gene variant in transthyretin. This affects about 50,000 people worldwide, and the median survival is only 4.7 years from diagnosis. So what happens in this disease because of the genetic variant, the TTR, or transthyretin, misfolds on itself, and this accumulates as amyloid deposits in organs and tissues. So it causes polyneuropathy, which is what this medication is indicated for. It also causes cardiomyopathy. This medication is not indicated for that. It's only for the polyneuropathy. So it's administered as a sub-Q injection every 3 months by a healthcare professional. And there could be reduced serum vitamin A levels, so that may need to be supplemented as well. There is some more information here about polyneuropathy of this type of amyloidosis. I just want to bring your attention to the treatments. They do mention orthotopic liver transplant, which will remove the primary source of the variant TTR. Of course, that would be the most invasive treatment you could go with. Then there is also, in addition to vutrisiran, there is another agent that is very similar, patisiran, or Onpattro. And there's also inotersen, or Tegsedi, which is also indicated for these patients. So in the trial, they did compare vutrisiran to patisiran, and they did find that it was, I believe it was, okay, they're saying here, change in neuropathy from baseline to 9 months was significantly improved for vutrisiran versus placebo. But when you look down to the last point there, the endpoints, they were non-inferior between vutrisiran and patisiran. The next product is olipudase alpha, or Zenpozyme, and this has all 4 of the designations: first-in-class, orphan, priority, and breakthrough. This is a product that's used for the treatment of acid sphingomyelinase deficiency in adult and pediatric patients without CNS manifestations of the disease. So it's basically an enzyme replacement treatment. So it's a direct treatment of the disease. So it's administered as an IV infusion. There's an adult versus a pediatric dose, and then it's administered every 2 weeks on a maintenance regimen. Let's see. Let's move along to the next page. There's some more information there about this acid sphingomyelinase deficiency disease. It's a lysosomal storage disease, rare, progressive, often fatal, and the genetic variant results in reduced activity of this enzyme, acid sphingomyelinase. The treatments are generally supportive care, and this product is the first treatment that provides an exogenous source of ASM. So the trials, one was in adults and one was in pediatric patients, both found that it was effective, and it was also given an open label as an extension trial for both, and they continued to show improvement. Okay, we have one new medication for kidney disease, and I wish I could ask, if you were all in the same room, how many have already looked at putting this on formulary? Okay, so it's terlipressin or Terlivaz. It's a first-in-class orphan drug with priority review. It's a vasopressin receptor agonist for treatment of adults with hepatorenal syndrome and rapid reduction in kidney function. So it's a synthetic vasopressin analog with twice the selectivity for vasopressin V1 receptors versus V2 receptors. It also acts as a prodrug for lysine vasopressin, and it has pharmacologic activity on its own. So it's administered by IV injection every 6 hours. Patient is reassessed after 4 days or on the 4th day of treatment. And then depending on how the serum creatinine is reacting, the dose is either reduced or continued at the same level. And if a patient has serum creatinine greater than 5, they won't get any result from this drug, so it shouldn't be used. There is a boxed warning about severe fatal respiratory failure, especially in patients with volume overload or acute on chronic liver failure. So the CONFIRM trial is what was used to bring this drug to market. And essentially, they did find that it was more effective than placebo. One note here, the third bullet down there, is that most patients in the trial also received albumin, 83% of the patients with terlipressin, 91% with placebo. And when you look at the place in therapy, hepatorenal syndrome type 1, it's a form of acute kidney injury and cirrhosis. 3-month survival is 20 to 40%. Terlipressin has been in use in the EU for Europe for 30 years. So it has taken a while to come here to the US. And one note also, the last set of bullets there, that society guidelines have added terlipressin for medical management of hepatorenal syndrome with acute kidney injury, but they've only really suggested it for use. They haven't recommended it. So I know that this is something that has come to question when it's been brought up for formulary addition. Okay, we have 4 new medications for neurological or neuromuscular disorders. The first of these is ublituximab or Briumvi. This is a CD20-directed cytolytic recombinant monoclonal antibody for treatment of relapsing forms of multiple sclerosis in adults. So this is administered by IV infusion. First dose is 150 milligrams, second dose 450 milligrams 2 weeks later, and subsequent doses are every 24 weeks. Patients should be screened for hepatitis B and serum immunoglobulins prior to the first dose, and also pre-medicated with corticosteroids and an antihistamine before each infusion. There are infusion reactions, which is why you have to give pre-medication. So patients need to be monitored for at least 60 minutes after the first 2 infusions. Here, the studies are the ultimate 1 and 2 trials. And basically, when they compared the medication ublituximab versus teriflunomide, another medication used for relapsing multiple sclerosis, they did see the rate ratio for adjusted annualized relapse rate was significantly better with ublituximab. And then on the right-hand side, we have different disease-modifying therapies for multiple sclerosis. So ublituximab is another one of these added to the monoclonal antibodies. And you can see the other products that are listed there. The next product is for an interesting disease. This is sodium phenylbutyrate and ursodiol, Relyvrio, for an orphan disease prior to review. It's for ALS, amyotrophic lateral sclerosis in adults. So this product, they don't really know exactly how it works, but it prevents nerve cell death by blocking stress signals within mitochondria and endoplasmic reticulum. So it's dosed orally. It's available as a packet. So the packet contains both of those drugs. It's administered orally daily for the first 3 weeks, and then 1 packet twice a day. It does have some drug interactions. It also has a high sodium content. And there's problems if patients have enterohepatic circulation disorders because of the oral absorption of this medication, the GI absorption. So as far as the trial, it has been found to provide benefit versus placebo. And place in therapy, ALS is a disorder of the motor neuron degeneration that leads to progressive muscle weakness. Median survival is very short, 3 to 5 years from symptom onset, although there are some patients that survive greater than 10 years. Most common cause of death is respiratory failure. And there are other FDA-approved disease-modifying treatments that are listed there, and investigational treatments include stem cell therapy and gene therapy. Next product is daridorexant or Qvivic. This is for insomnia. It's a dual orexin receptor antagonist, taken orally once nightly within 30 minutes of bedtime, at least 7 hours prior to planned awakening. It's a Schedule IV controlled substance. And you also have to be careful if patients have complex sleep disorders, after receiving this medication, that would be a reason to discontinue it, like sleep driving or sleepwalking, things like that. So the trials did find it to be effective versus placebo. Place in therapy, there are lots of medications to treat insomnia, and this falls into the dual orexin receptor antagonist with 2 other drugs, lemborexant and suvorexant. Next product is ganaxolone or Zitami. This is a first-in-class orphan drug with priority review. This is for a disease, an orphan disease that affects mostly children. It's called cyclin-dependent kinase-like 5 deficiency disorder. And the indication is patients 2 years of age and older. So the mechanism of action is it's a GABA A receptor positive modulator. So it's specifically for the treating the seizures that these patients have. It's dosed orally as an oral suspension, and doses vary depending on the patient's weight. It is taken with food. It is also a Schedule V controlled substance, so there is somnolence along with it, and patients also should be monitored for some of the drug interactions. And also, you want to be careful, you don't want to withdraw the medication abruptly because it could stimulate seizure activity. So this is a picture of a child that has this disease. There's some more information there about the disease. These patients do get refractory seizures beginning in infancy. It impairs their development neurologically. These patients can't walk, talk, or care for themselves. So disease-modifying treatments are in development. Again, this medication is only for the seizures that these patients have. But it's whatever we can do to help them is going to be of benefit. There are 2 new medications for eye diseases, and I think we're getting close to the end. The first of these is amidenapag or isopropyl ophthalmic solution, or Amlanti. This is a prostaglandin E2 receptor agonist. It's used to reduce elevated intraocular pressure in patients with open-angle glaucoma or ocular hypertension. It's dosed ophthalmic, so it's 1 drop of solution in affected eye once daily in the evening. When looking at the clinical trials, it did basically provide the same results as is seen with timolol or latanoprost arms. And some of the safety considerations is that it can cause increased pigmentation of the iris, the periorbital tissue, and eyelashes. The other ophthalmic medication is Vabysmo or faricimab. This is a VEGF and angiopoietin-2 bispecific antibody. It's indicated for 2 things: neovascular wet age-related macular degeneration and diabetic macular edema. So the dosing varies depending on the indication. And the things to note under the dosing is that for neovascular age-related macular degeneration, it can be dosed as infrequently as every 16 weeks. And you'll see on the next slide that that's important for this disease state. And then for diabetic macular edema, it can be dosed as infrequently as every 8 weeks. It does have some safety considerations. It's an intravitreal injection, so it can cause endophthalmitis and retinal detachment, and intraocular pressure can increase transiently within 60 minutes of the injection. So in the clinical trials, I know that one chart on the left is very, very tiny, but that's not really the clinical trial. It's just a comparison of other agents that are available for neovascular age-related macular degeneration and the interval that they can be administered. So the 16 weeks is the benefit of this drug. With diabetic macular, I forget what the other word was, edema, macular edema, that chart there is just showing you the how often it was dosed compared to the other medication, and then also the primary endpoints where those were achieved. And basically the best corrected visual acuity difference from baseline to 1 year was non-inferior with this product versus personalized treatment interval versus aflibercept every 8 weeks. So they had, it was non-inferior. All right, so now we're going to move over to the new oncology medications. We're not going to go through them in depth the way we did the other medications. Instead, I have tables that cover a few medications at a time. So I believe there's 9 of them altogether that we're going to briefly talk about. I'm just going to point out some major issues. So the first of those is mirvetuximab soravtansine, which is Elahere, antibody drug conjugate folate receptor alpha directed antibody and microtubule inhibitor conjugate. Very big mouthful. This drug is for epithelial ovarian fallopian tube or primary peritoneal cancer that is FR alpha positive. That's why it's a first in class. Also platinum resistant and after 1 to 3 prior systemic treatments. This medication is administered by infusion, and actually these are all injectable biologicals that we're talking about right here. There are infusion reactions, so the patients need to be on pre-medications, including antihistamine, steroids, antipyretics, and antiemetics. It also does have ocular toxicity. So it's administered as an IV infusion every 3 weeks until either disease progression or unacceptable toxicity, and ocular toxicity must be monitored for using ophthalmic exams prior to treatment and every other cycle for the first 8 cycles. The next product, Imjudo, is a CTLA4 blocking antibody, and this has 2 indications. The one indication is unresectable hepatocellular carcinoma, is the most common type of liver cancer that exists. And so this is a new therapeutic option, which is always good to help improve the prognosis of these patients. And then the last product there, Kimtrac, is a bispecific peptide HLA-directed CD3 T-cell engager for uveal melanoma that's unresectable or metastatic in patients that are HLA-A02:01 positive. And just want to mention here that this drug can cause cytokine release syndrome. It's a 15 to 20 minute weekly IV infusion. And it's also a category 1 preferred treatment option by the NCCN, the National Comprehensive Cancer Network. So the treatment with this product has resulted in longer overall survival compared to control therapy. So it is pretty much a breakthrough for uveal melanoma. Here we have a few more of the new oncology medications, also biologics. Lunsomio is a bispecific CD20-directed CD3 T-cell engager for follicular lymphoma. It does have a boxed warning regarding cytokine release syndrome. It's also administered by IV infusion. And let's see what else here. Follicular lymphoma is the most common slow-growing form of a non-Hodgkin's lymphoma. It accounts for about 1 in 5 cases. So again, it's good to have a new drug for patients that are not responding to other therapies. Opdualag has actually 2 products in it, nivolumab and relatlimab. This is a programmed death receptor 1 blocking antibody, which is the nivolumab, and lymphocyte activation gene 3 blocking antibody, the relatlimab. It's for advanced melanoma that's unresectable or metastatic in patients 12 or older. The next product, Rolvedon, is actually not an anti-cancer agent, but it's a recombinant human granulocyte growth factor. So the advantage of this medication is that it's a long-acting sub-Q injection that's administered once every chemo cycle, about 24 hours after the cytotoxic chemotherapy. So that's the advantage that it provides. And then the last product there, Tecvali, is the only other one in 2022 that has a REMS program along with it. This is being used for multiple myeloma after at least 4 lines of therapy. It's a bispecific B-cell maturation agent, and it's only available through the REMS program to help mitigate the risks of cytokine release syndrome and neurologic toxicity, including ICANS, which is immune effector cell-associated neurotoxicity. So prescribers must be educated on the importance of monitoring patients for signs and symptoms of CRS and neurologic toxicity, including ICANS. Then there's some other new oncology medications that are not monoclonal antibodies. We have Krazati, Adacrazib, which is a RAS GTPase inhibitor for non-small cell lung cancer. This is an oral medication administered twice a day. We have Futibatinib or Litgobi, which is also a kinase inhibitor administered orally once a day. This also can cause ocular toxicity and hyperphosphatemia, so that's something to be aware of. The third one there, Pluvicto, is actually interesting. It's a radioligand therapeutic agent. This is for prostate cancer, and it's administered IV every 6 weeks, up to 6 doses. And I believe there are some, I noticed online there's some supply problems with this product, so that might be something you're experiencing in your institutions if you have it on formulary. And then the last product, Rezlidhia, is also administered orally. It has a boxed warning for something called differentiation syndrome, which actually is very severe and can be fatal. It's associated with rapid proliferation and differentiation of myeloid cells and may be life-threatening or fatal. Symptoms of differentiation syndrome in patients treated with Rezlidhia included leukocytosis, dyspnea, pulmonary infiltrates, kidney injury, fever, edema, pyrexia, and weight gain. And this differentiation syndrome can occur as early as 1 day after the dosage initiation, up to 18 months after the patient's been on therapy. So most patients do recover with treatment or dosage interruption, but it's definitely something to be on the lookout for. Okay, so even though we finished the 37 medications, and hard to believe it's only been an hour, I did want to talk a little bit about some of the CBER drug approvals for 2022 as well. So CBER, I mentioned at the very beginning of the presentation, we have CDER and CBER. So the 37 were through CDER side of FDA, the Center for Drug Evaluation and Research. So the FDA Center for Biologics Evaluation and Research, they regulate the biological products such as vaccines, blood and blood products, cells, tissues, and gene therapies for prevention, treatment, and diagnosis. So these products all go through a biologics license application or BLA. So they do review the human gene therapies, which is the reason that I wanted to, take a look at the CBER approvals. Human gene therapies are various types of therapies. They're ones that either replace a disease-causing gene with a healthy copy of the gene, they inactivate a disease-causing gene, or they introduce a newer modified gene to help treat a disease. And then gene therapies, they include viral vectors, human gene editing technologies, patient-derived cellular gene therapy products, and this is where CAR T-cell immunotherapy also falls in. So I'm just going to cover some of the CBER drug approvals, not all of them, but ones that I thought you might be interested in. So the first of those is Adstiladrin, and this is the first adenoviral vector-based gene therapy for bladder cancer that is BCG unresponsive, non-muscle invasive, and with carcinoma in situ with or without papillary tumors. So in the clinical trials, 51% of the patients using this therapy achieved a complete response, and they had disappearance of all signs of cancer as seen on cystoscopy, biopsy tissue, and urine. The median duration of response was 9.7 months. 46% of the responding patients remained in complete response for at least a year. So this definitely provides, a benefit to those patients with bladder cancer that's BCG unresponsive. The second product, Carvykti, is actually a CAR T therapy, and this is for multiple myeloma. Oops, let me go back there. It's for multiple myeloma. that is relapsed or refractory after 4 or more lines of therapy. So Carvykti is a one-time infusion, as generally CAR T therapy and most gene therapies are. And 98% of 97 patients that were treated in the clinical trials responded to the treatment, with response lasting a median of 22 months. So very significant response by these patients. Cost, just to let you know, some of the costs of these therapies. Cost for this CAR T therapy, what I found online anyway, is $465,000 for the one-time dose. The next product, Hemgenix, actually has the distinction of being the most expensive product available in the world. It is actually $3.5 million for the single dose. So why is it so expensive? This medication is the first gene therapy for hemophilia B. So it uses a harmless virus to carry into the liver a highly functional version of the gene that contains the instructions for making factor 10 or factor 9. So once it's there, this modified gene is used by the liver to produce the missing factor 9. And it's a single dose, single infusion, and it keeps the factor 9 levels raised for long term. So that limits the hemophilia symptoms, and it helps to reduce the need for prophylactic therapies. So, it is certainly a breakthrough medication and one that will help many people. I don't know how many people have received it yet, but knowing that it's out there, I'm sure a lot of people are anxious to use it. Skysona is another gene therapy cell suspension. This is for an ultra rare brain disease called cerebral adrenoleukodystrophy. It may sound familiar. It was actually the disease that the boy had in the movie Lorenzo's Oil, which is actually kind of an old movie at this point, so I don't know how many people have seen it. But there's only about 50 new cases per year in the US, so very few patients out there. It does cost a lot of money. It's also $3 million for a one-time infusion. Zynteglo is another product that is also a stem cell, autologous hematopoietic stem cell-based gene therapy, this time for beta thalassemia in adult and pediatric patients who require red blood cell transfusions. Their cost for this is $2.8 million. So bottom line is all of these gene therapies are wonderful breakthroughs, very expensive, but I guess if you look at all the costs involved in treating these patients and managing them, to have a gene therapy that maybe can correct their disease and prevent all the therapies that they need, all the hospitalizations, I'm sure it's worth the money when you actually calculate all that information out. The last product there, also wanted to mention this one, Rebiota is the first fecal microbiota product available. And of course, the prevention of recurrence of C. diff infection in adults following antibiotic treatment for recurrent CDI. So it's a single rectal dose of 150 mLs. And this costs, from what I saw, about $9,500 for the dose. So just wanted to provide you with some information on those CBER approvals as well. And at this time, we have some time to go through the learning assessment questions, and then we'll have some time for active Q&A. So I'll ask for the first question, and then I think we have polling questions that we can bring up. So first question is, which one of the following is true regarding new medications with REMS programs? Pick one correct answer. There are 10 new medications approved in 2022 that have REMS programs. Second answer is mavacamten Camzyos is only available through a REMS program to allow for regular monitoring of heart function, concomitant medications, etc. Third response is terlipressin. Terlivaz is only available through a REMS program to make sure it is only used for patients with hepatorenal syndrome and rapid reduction renal function. Or the last response, daxibotulinum toxin A. Daxxify is only available through a REMS program to monitor for life-threatening swallowing and breathing difficulties. And now we'll take a few minutes while people vote. I'm not sure I can see the voting responses, so you might want to tell me. Let me see.
It seems like there's still some coming in, so I will end the poll in just a second when they slow down.
Gotcha. All righty. So it looks like you all got the correct answer. Who voted for mavacamten? Camzyos is only available through REMS program. That is the correct answer. There were only 2 medications approved in 2022 with REMS programs. One was an oncology agent and mavacamten. Terlipressin is not available through REMS program. It's much more freely available. And the daxibotulinum toxin A is not available through REMS program. It's more freely available. So thank you for those responses. And there's the correct response there. Okay, so the next question is, which of the following is correct regarding the new medications of 2022? Answer A, there were only 2 new oncology medications approved in 2022. Answer B, 5 of the 37 new medications approved through CDER were monoclonal antibodies. Answer C, more than half of the new drugs approved in 2022 were orphan drugs. Or D, nearly all of the new drugs of 2022 were priority review and breakthrough drugs. Take a minute. All right. Okay, so yes, you did get the correct answer. C was the correct answer. More than half of the new drugs approved in 2022 were orphan drugs. So answer A is not correct because there were more than 2 new oncology drugs. I think it was 9. As far as the new medications approved through CDER that were monoclonal antibodies, there were 15, I believe. Nearly all of the new drugs at 22 were priority review and breakthrough. It certainly did feel like that, but it was actually less than half that were priority review and breakthrough. So answer C was correct. All right, question 3. Which of the following statements is false regarding new gene therapies? A, CAR T cell therapies are gene therapies approved by FDA Center for Biologics Evaluation and Research. Remember, we're looking for which one's false. B, gene therapies are inexpensive treatments that are easy to administer. C, gene therapies are primarily used for cancers and genetic diseases. Or D, early adoption of gene therapies is hampered by getting payers on board, risk benefit of the drugs, and uncertain safety concerns. So let's see what you think. We didn't really fully talk about all those things, but I think you might have an idea. Okay, so B was the correct answer. They certainly are not inexpensive and easy to administer. So yes, that was correct. You're right. And the next question, let's see. There's the correct answer. Next question, which one of the following new drugs and indications is not correct? Okay, this is where the matching test comes up, matching the drug and its indication. So which one is not correct? 3 are correct, 1 is wrong. So the first one is lenacapavir. Sunlenca is for multi-drug resistant HIV. B, gadopicolol, Illucerum is a contrast agent for MRI. Tirzepatide, Mounjaro, is for type 2 diabetes. Or ublituximab, Briumvi, is for insomnia. Which of those is incorrect? And I know I threw a lot at you tonight, but I'll bet anything that you know you remember some of these, or you already knew them, I guess. Okay, yes, that's correct. Ublituximab is not for insomnia. It's actually for multiple sclerosis. Daridorexant, Quviviq, was the one that was for insomnia. Okay. And then our last question, which one of the following orphan drugs and indications is not correct? So this is orphan drugs. First one is sutimlimab and JMO is for hemolysis with cold agglutinin disease. Sodium phenylbutyrate and tar-ursodiol Relyvrio is for generalized pustular psoriasis flares. Ganaxolone Zotami is for seizures with cyclin-dependent kinase-like 5 deficiency disorder. Remember that little girl? Or vutrisiran Amvuttra is for polyneuropathy of hereditary transthyretin-mediated amyloidosis. This might be a harder question, but if you look at these answers, I think one of them might stick out as being the incorrect answer. So just take your best guess. Okay, so we do have people all over the place, but B was the incorrect answer. The first one, third one, fourth one are all correct, but Relyvrio was for ALS. The sodium phenylbutyrate, it should be butyrate, and tar-ursodiol, Relyvrio is for ALS and not for GPP flares. It wasn't for, a skin disease. Okay, so that's the end of the questions. And at this point, I'll open up the floor and see if anybody has any questions that you want me to review. Also do want to mention that you will be getting the slides. I will send over this copy and there's links in the slides that you can go to all of the clinical trials, all the package inserts, all that information is contained within the slides. So even on a PDF, you should be able to get those links. So I thank you all for your attention and I look forward to any questions you might have. I'm not sure if I don't see any questions. I don't know. Are there any questions?
Not yet.
Okay. I know it was a lot of information, but it's something you can keep and refer to in the future if you want to.
We have a question.
Okay.
How many years do these drugs have licensed brands for?
Have license. How long is the license good for?
Yeah, how many years do these drugs have
Well, that's
licensed?
a good question.
Yep.
Yeah, I think it's generally, initially it's actually 20 years, but that's from the time that they initially provide it as the patent. So by the time they bring it to market, it depends on how long it takes them to bring it actually to market. So generally it's about 14 years once the drug gets to market, but the entire patent is generally about 20 years. And of course, that's if they don't bring a different indication to market or some variation of the drug. If it's an IV drug, it becomes available as oral or sub-Q or a different, if in some way they improve on the drug, then that extends the patent even further. Does that help?
Thank you. We have another question. Have you heard of plans for value-based contracting for costly biologic therapy?
That's a great question too. Value-based therapies. I know that I definitely have heard discussions about that, and I don't offhand recall which drugs in particular, not these drugs, but other drugs that are on the market. Generally, like cardiac drugs tend to be ones where, if there's a claim that the drug is going to provide significant benefit, that the manufacturer will actually stand behind that and say that they'll pay for it if it doesn't provide that benefit. So it's possible that there could be some value-based contracting with some of these. But again, you see that the studies, the clinical trials are generally with placebo. So, you know, if a drug is coming into a market where there's a number of other therapies that are already being used for that indication, it's unlikely that there would be value-based contracting for that, because there's, you know, they're not going to be able to do trials to show that their drug is better, and they wouldn't want to do those trials because it would be a tough road. So if a drug is the initial drug, the only, you know, one that will actually address the disease itself, like that mavacamten, potentially that could be one, you know, cardiac disease that actually addresses the specific problem with that disorder, then possibly that might be something that the manufacturer would be willing to stand behind with that type of contract.
Thank you. We have another question in the chat. Having done this over the years, is there trends you see in disease states or therapy types that you see more approvals for?
That's a great question. Definitely a lot of oncology drugs. You know, every year it seems like there's more. A lot of orphan diseases, like you can see, it was over half of all the drugs were orphan diseases. So all those niche areas where the manufacturers, like there's some manufacturers that are focusing only on orphan drugs. So as well as there are manufacturers that focus on, you know, only antibiotics or like HIV, you know, they're all going to focus on certain things. But so I think definitely a focus on orphan drugs, and there's a huge price tag with those, but there's also a very limited patient population. I think, you know, I wanted to provide the information about the gene therapies because gene therapies are kind of exploding. And I think there's a, you know, we're seeing that we're going to have lots more coming to market. That's going to be a real focus area in the next year, the couple years coming up, and probably the future, that there's going to be more focus on gene therapies because, you know, these are providing such a huge benefit, first of all. And doesn't matter how small the patient population is, if this is something that's going to change somebody's life and allow them to live a longer life, you know, you're almost willing to pay anything. But I think there's going to be more of a focus on gene therapies. And I think the orphan disease focus will continue, and oncology. As far as another area, you know, it used to be that they thought monoclonal antibodies were going to kind of just take over, but we're seeing more oral therapies coming to market, especially for oncology, the TNIBs, and now we're seeing TNIBs in various other diseases as well, a lot of the autoimmune diseases. So I think we're going to see, you know, more of that as well, more focused, you know, on specifically what cytokines we have to look at, and focus the drugs on those specific cytokines. So much more focused therapies and in those different areas.
Thank you. Here's another question. Why do you think USA was the 44th country to approve anacalase in thermal burns?
Yeah, that's a good question. I don't know. I didn't really look into it in too much depth, but it might have either been that the manufacturers just didn't like, maybe the FDA didn't like the information that they were providing, or they felt they already had the drug in so many other countries that they didn't really need the US. I don't know. I honestly don't know. I don't know the answer to that question. But I could look it up, and, you know, if you want to email me, I'll find out and get you the information. But yeah, that was kind of surprising. Actually, terlipressin was the other one where it's been approved in the EU, but they had trouble bringing it to market in the US. And I think people are having trouble using it. Like, they don't really want to use it in the US, but, you know, that happens now and then.
And last question. Great presentation, Liz. Could you explain more about different pricing and when they apply? Example, 340B, WP.
Well, 340B, you know, that's a good question. I don't know. When I look up the pricing information, they only give the list price. Because, you know, I'm just using the internet for that information. So 340B pricing is never provided. Just if you look on the internet. I think there's potential for 340B pricing, and I know from my experience that generally speaking, when new drugs are added to like formulary or contracting, there's always a request that there's a 340B price. Many new drugs don't make it onto contracts too early in their, you know, once they've been approved, especially if they're brand new first-in-class agents where they don't have any competition, you know, you're not going to get contracts for it, you know, in the regular contracting world. 340B though, I would expect that there would be some pricing decrease for, you know, for those, for drugs that are used in the outpatient setting. It would make sense.
Great. Same person asking another question. Since the NIOSH list hasn't been updated, are there other recommended resources to identify hazardous medications?
That's a great question. Yeah, NIOSH is always so far behind. I think they just came out recently with an updated list to, I forget what year, but it was like they were so far behind with their last list. That's a tough one. I guess, you know, you can get that information from the manufacturer. So when you put a new drug on formulary, you know, ask the manufacturer for that information. That would be your best source, is to go through the manufacturer.
Great. That's all.
Okay.